posterior ligamentous system just lightly, and you find that there is a fair amount of sort of slackness, so it's not the tension that you normally find. And then you go to the bone, because that's where most of the nociceptors are, in the periosteum and the ligamentous connection, and it's very sensitive. Think very much about, here's a ligament that's doing its best to kind of keep this stable, but it's gradually breaking down. And then we go into doing our tests for hypermobility. So what would be the route then to go that way? What would you do first? Yeah, can you be a little bit more specific? Because we want this to be a sort of progressive testing.
That's the things that your palpation directed you to. Try to stress that turn of ligament.
Before that, what was the physiological reason for developing instability? What did we say between the arthrokinematic movement? We could start to translate. So what we could do to start with would be to do an anterior-posterior translation or a posterior-anterior translation. This is not particularly stressful, but we should be able to compare it with a normal joint, which is very little movement, and compare it with the unstable joint where we start to get more range of motion. Now, it doesn't always work, because we know instability can sometimes be in one direction. But this is a very useful starting point, just to go into little translation movement. Then we can go into the stress testing. Have a look at it at various ranges. Have a look at it in terms of absorbing compression and rotation and lateral flexion, so that we can kind of build up to testing for instability.
Aren't PAs and APs under the category of stress tests?
It depends how you use them. Any test can be taken to a stress point if we take it to its limit, just the same as any test can almost be used as a treatment procedure as well. Yeah. So I would I tend to use those really to identify a level. I don't usually use them to do any great pressure, because I think that the sideline translations are better for me. So, if those others work for you, that's fine. I'm just here to sort of suggest a few, altered things, but sometimes you don't want to change because you're getting good findings, and that's reasonable. I mean, I would expect that. And I have my prejudices too. So, we don't always go through looking for instabilities. If I went up the back and everything felt normal until I came to one that felt stiff, I wouldn't go through all of this kind of problem. And particularly if the patient, just had got this bit of a pain, they'd done something that was particularly severe, such as shoveling or something like this, and they'd got this pain in the back, and I felt that the ligamentous attachments seemed to be always the same part apart. There was no sensitivity particularly between the ligaments. I wouldn't go for doing a whole set of instability testing. I don't think it's necessary on many patients. Just the same as I don't look for compression and torsional strains on every patient.
What about the person that was unstable but in a particular direction that would be identified with? Maybe you went through and did gentle PAs on every segment and found that they were all fine except maybe one was stiff. That could still be hiding an instability at one of those that was only identifiable in rotation, say, right? So you need to go through and do.
I think what you'll find is, though, that on palpation or on PA pressures, that joint will be always sensitive, regardless. It's always sensitive. And I find that regardless of the particular movement, you'd nearly always find that the posterior ligamentous structures, because it's so important for the absorption, is nearly always very sensitive. And under those circumstances, it's really well worthwhile going through all this.
I'm a little confused. After you were talking about PIVMs and you thought that you found a segment that might be a little unstable, is that when you go to, are you talking about the PA translation? Are you talking about prone PAs, or are you talking about when you get them in sideline and you're checking each joint and locking and flexion and pushing through the knees?
Yes, that's what I'm talking about. That's the route I would take on those.
Okay.
But many people, I don't sort of go through that. I mean, I think instability is one of these things we've got onto, and now everybody's got instabilities. You know, it seems to be like the pendulum has swung quite far. I mean, Cyriax didn't even think about instabilities. He was there manipulating and so on, you know. Are we getting any better results than he did? I doubt it very much. Maitland didn't address instabilities at all in his system. You know, so here we go. You know, here we've learned something. This new thing has come up now, so everybody's got them. And perhaps we all have to some extent, you know, looseness and so on. Any other things on this? Okay, so if we were to spend just 5 minutes now on trying to produce an algorithm, a flow chart of what we would do and when. And this will enable us, when we go and do some practical work, which I like to do before lunch anyway, to just see when we need to take a particular pathway. And I think this is a really important thing. So, get writing, Ken, in terms of trying to produce a flow chart, and let's see how good we can get. So see how you do with your group, and I'll put something up on the board.